It's Patrick Hutzel from Intensive Care at Home, where we provide tailor-made solutions for long-term ventilated adults and children with tracheostomies and otherwise medically complex patients in intensive care by improving their quality of life, and where we also provide tailor-made solutions to hospitals and intensive care units to save money and resources whilst providing quality care. In last week's blog, I talked about home mechanical ventilation quality standards. You can check out last week's blog by clicking on the link below this video. In this week's blog, I want to answer a question that we get quite frequently from our readers and also clients. And the question this week is, can you be discharged from hospital with ventilator, tracheostomy and feeding tube? Many families in intensive care have loved ones in ICU or pediatric ICU with long-term ventilation and tracheostomy requirements. Their loved ones usually experience either difficulties, delays, or complete failure in weaning off the ventilator and tracheostomy. So, what are the reasons for mechanical ventilation and tracheostomy in intensive care in the first place? Causes of admission to ICU or pediatric ICU for mechanical ventilation and tracheostomy are acute respiratory failure with underlying chronic comorbidities, 176 or 24.4%, exacerbation of chronic obstructive pulmonary disease, 222 or 34.4%, neuromuscular diseases, 200 or 27.8%, for example, Guillain-Barré syndrome, or also motor neuron disease or MND. Surgical patients, 77 or 10.7%, thoracic dysmorphism, 28 or 3.8%, and obstructive sleep apnea syndrome, 16 or 2.2%. Percutaneous tracheostomies were 65.9%. Major complications after tracheostomy were 2%. 427 tracheostomies were evaluated for decannulation, which is 96 or 22.5% were closed. 175 patients or 41% were discharged with home mechanical ventilation. 114 patients or 26.5% maintained the tracheostomy despite weaning from mechanical ventilation, and 42 patients or 10% died or lost. The reference you can find on the link that I put below this video, where you can find a link to the study there. And the title of the study is Tracheostomy in Patients with Long-Term Mechanical Ventilation, a Survey. So further to this reference, what leads to prolonged mechanical ventilation, tracheostomy, and then the ability to wean a critically ill patient off the ventilator are the inability to wean somebody off the ventilator. So this often begins with prolonged induced coma, intubation, which is insertion of the breathing tube or endotracheal tube, and the failure to extubate. Extubation means the removal of the breathing tube. Generally speaking, intubation for respiratory failure leads to induced coma, mechanical ventilation, and this also goes hand in hand with a nasogastric tube or a feeding tube. Again, if weaning off the ventilator and the breathing tube extubation cannot be achieved, the next step is to perform a tracheostomy. So you may be wondering, when is the right time to perform a tracheostomy? So in order to answer that question, I have put some articles and videos or links to articles and videos below this video in the written version of this blog, or if you're watching this on YouTube, just click on the link below the video. That'll get you to our website where you have access to all of the following articles and videos as well. So the first link that I put in there to an article and video is, how long can a breathing tube or an endotracheal tube stay in? The next question is, how long should a patient be on a ventilator before having a tracheostomy? The next question that you may want to do some research about is, what are the risks and benefits of a tracheostomy? And last but not least, why would a critically ill patient in an induced coma need a tracheostomy in intensive care? So you can find those links to those articles and videos again in the written version of the blog. Next, when a tracheostomy is done, a PEG tube or feeding tube, also known as gastrostomy, is done as well. A PEG is a permanent feeding tube through the abdominal wall into the stomach. Nevertheless, it is often doctors' and family preference whether a PEG tube is inserted or a nasogastric feeding tube is left in place to continue feeding. Anybody on a ventilator with either a breathing tube or a tracheostomy is unable to eat orally, hence the nasogastric feeding tube or the PEG tube. In either case, with the tracheostomy, mechanical ventilation and feeding tube, a patient can definitely be discharged home with a service like ours, intensive care at home. Mechanical ventilation, tracheostomy and feeding tube is definitely not an obstacle for intensive home care. Ideally, patients are medically and hemodynamically stable before going home, and they should ideally be off intravenous inotropes or vasopressors for hemodynamic instability. However, low doses of inotropes or vasopressors are certainly not a hindrance for intensive home care, because intensive care at home provides an intensive care substitution service at home. Multiple care and treatment options are available at home for long-term ventilated patients with tracheostomy and feeding tubes. So, for example, we are providing quality of life nursing services for mechanically ventilated adults and children with tracheostomy as a genuine alternative to a long-term stay in intensive care. And we're also providing quality of end-of-life care or palliative care nursing services for mechanically ventilated adults and children with tracheostomy, again, as a genuine alternative to a stay in intensive care. And obviously, this also includes ventilation and tracheostomy weaning at home. Especially when it comes to prolonged weaning in intensive care, ventilation and tracheostomy is much better at home because it's being done in a more holistic and therefore patient and family-friendly environment. How much nicer is it being at home compared to a sterile intensive care unit, especially if you can get the same care and treatment at home compared to ICU or pediatric ICU? End-of-life care again is also part of our intensive care substitution service at home. If you think about it, when it comes to end-of-life in intensive care, nobody wants to approach their end-of-life in intensive care or pediatric intensive care, and we are enabling intensive care or pediatric intensive care patients to leave the environment and approach their end of life at home. Last but not least, you may also wonder, is this a safe option? To see for yourself, please check out our case studies so you can actually see that it's very safe to provide intensive care at home services. And also, we are providing intensive care at home services exclusively with intensive care and pediatric intensive care nurses that have a minimum of 2 years ICU or pediatric ICU experience and have completed a postgraduate critical care certificate. In fact, our nursing team on average have a total of 8 to 10 years ICU and pediatric ICU experience and a postgraduate certificate. Furthermore, on top of our highly skilled nursing team, we also have achieved third-party accreditation for intensive care at home nursing, including mechanical ventilation. You can find out more about our quality and accreditation again on the link on our website to the accreditation and quality. So if you want to find out how we can help you to get your loved one out of intensive care, including palliative care or long-term acute care, also out of a nursing home, or if you find that you have insufficient support for your loved one at home on a ventilator, if you want to know how to get funding for our service, or if you have any questions, please send me an email to patrick@intensivecareathome.com. That's Patrick, P-A-T-R-I-K, @intensivecareathome.com, or call me on one of the numbers on the top of the website. Also, have a look at our career section. We are currently hiring ICU and pediatric ICU nurses for clients in the Melbourne metropolitan area, northern suburbs, Sunbury, Mornington Peninsula, and in South Gippsland, Victoria. We are an NDIS, TAC, and DVA approved community service provider in Australia. Also, have a look at our range of full service provisions on our website. We have also been part of the Royal Melbourne Health Accelerator program for innovative healthcare companies earlier last year. Thank you for tuning into this week's blog. This is Patrick Hutzel from Intensive Care at Home, and I'll see you again next week in another update.